Good afternoon. We want to thank everybody for joining us today for our quarterly provider webinar. My name is Carolyn Schoaf. I'm a provider network trainer with Partners. Beth Lackey, our provider network director, is unable to be with us today. She sends her regrets. She has reviewed and approved the webinar content today that will be presented to you from various leaders across our organization, and we hope that you find this information helpful. As a reminder, we produce a webinar for you each quarter. All attendees are in listen-only mode, and this webinar is being recorded, and it will be posted to our Partners Training Academy library for future viewing. It should be available in about a week. At the end of the webinar, you'll receive a brief survey, and it's very helpful to us if you will take a moment to offer us feedback on the content and suggest topics for next quarter. For our agenda today, we have a robust list of topics. We're first going to summarize some provider council updates. Then Allison Crotty, our member engagement director, has prepared some information for after-hours crisis response that I will share with you. Then Jesse Green, a supervisor, will provide some updates. Joy Chestnut, with program integrity, will share information on reducing the risk of overpayments with a focus on service orders, comprehensive clinical assessments, and person-centered plans. Keisha Sandage, a consumer rights officer, will share some information regarding IRIS, and Danielle Sigmund will give an update on social determinants of health. We'll review some updates to the provider operations manual and end with communication bulletin items and upcoming trainings. So to get started, for our provider council updates, the current leadership will now be Beth Brown, who is our chair. Alicia Edmonds is our vice chair. Tegan Brown will be our secretary, and we appreciate their work in this leadership role. The Provider Council is a vital link that assists us with strategic planning for providers and members. We really value the feedback from the Provider Council, and it really helps shape some of the decision-making that is done here at Partners. We welcome all providers to attend. This is an open meeting. It occurs monthly, with the exception of December and July. It's held on the fourth Friday at 9:30 a.m. at our Hickory location. The multi-purpose room for training is in the basement of our Hickory location, and we would love for you to join us. Our next meeting is March 27th. After-hours crisis coverage and response. So again, this information comes from our Member Engagement Department Director, Allison Crotty. Over the last 4 months, Partners team has engaged in a multi-pronged initiative to lower ED use for non-critical behavioral health encounters. So this has been a multifaceted plan. At first, we surveyed providers about their after-hours crisis response. We're going to include bulletin reminders of first responder responsibilities. We performed some mystery shopping calls to providers after hours to test your response. We're working on crisis and ED use campaign with materials for members and families. These are ready for print at this time, and we'll be distributing those soon. Today, we're going to focus on the results of our mystery shopping, and we'll be following up with different providers, and we'll continue future mystery shopping as results improve. So going back to reducing unnecessary BHED use, during December of 2019, we surveyed providers for their crisis numbers. We looked at voicemail scripts, crisis materials, and we wanted to make sure we had information about your current practices. In January, we tested some of the first responder capability. We mystery shopped with 159 enhanced providers, calling them after hours to see what the member experience would be if a member had called for after-hours assistance. So now we are sharing some of the preliminary results with you. We're going to continue to share reminders to support your efforts We're going to be producing some FAQ pages. We're going to get information out through the bulletin and other means. So here are our preliminary results for the first round of after-hours calls. Of the 149 calls that were made to enhance providers by the Access Care staff, and again, they used those numbers that were in our Alpha system, unfortunately, only 5.66% of the calls that were made were answered by a staff person at the agency. In other words, a live answer where a human being answered the call if it had been a member that was calling. 10 of those numbers that were listed in Alpha were not in service across the 8 different provider agencies. So that means the system had outdated information in it. Less than 70% of the 149 working numbers were not answered did have voicemail capability. So some of these results were shared during the provider council meeting most recently. We did have some comments from providers that they would prefer we use the numbers in the individual crisis plan instead of the numbers in Alpha. So our operations team is reviewing this feedback to decide how to do the next round of mystery shopping. We want to look at the preliminary results as well, again, for the after-hours calls, that only 2 of the 95 voicemails left were returned by staff. So the partner staff stated when they called and left a mystery shop call that this was a test of your emergency number and we needed a return call back so we could assess how long it takes a member to get a call back when they leave a voicemail. Of those 95 calls, only 4 agencies returned the call. So we want to encourage you to make sure that your voicemail message includes what your process is, includes any numbers that the member may need to call again, and be mindful that even if you have an individual process for the individuals that you serve, for those members to call certain numbers, if there are individuals trying to assist a member in crisis, such as a hospital, law enforcement officer, or even family members, if they don't know that specific process that you have for that individual member, they may call your agency number and then follow the directions that are left for them if you have voicemail capability. So please keep that in mind. So again, of the 95, 4 agencies did return the call, but that means a lot of calls did not get returned. You can see here on this slide what that small sliver is. So given that data, we're definitely going to embark on another round of calls just within the next month to test those voicemail systems. And we're hoping to see an improvement in the experience that the members have if they call your agency after hours. We're sharing this slide for mystery calls made per service, but do keep in mind that we realized this data is incomplete due to an error in our tracking sheet. Again, it was our first opportunity to do mystery shopping, and we need to tighten up our tracking sheet to be sure that we are able to give clear results on the calls that were made. So this particular slide shows that there were partial results by the service type. You can see for CST, 2 of those numbers were non-working numbers or a voicemail with no return call. Of the ACT teams that were called, 7 of the 10 we did receive a return call. 3 of the 10 referred the person to an ED or to 911, which is concerning because that doesn't meet the service standard. For SAIOP, we had 1 non-working number, 1 answered live, 44% had a voicemail with no return call, 4 directed the caller to call our Hopeline number, and then or 911, 2 of each. For intensive in-home, 4 of the 69 were answered by a live person, which equates to 5%. 3 of the numbers weren't working that we had. 39 of 69 had voicemail recordings, but only 2 of those 39 returned the call for intensive in-home, which means 37 messages weren't returned. For SACOP, we had 2 called with 1 not answered and the other directed to another number with no voicemail capability. So again, some reminders for the expectations for after-hours coverage. All network providers have a contractual obligation and are bound by specific service definitions to provide this first responder capability. So at a minimum, the crisis plan has to include that contact information with a thought to what's going to help this individual mitigate a crisis for them. There needs to be availability for consultation by phone or face-to-face in a crisis before that consumer may access a higher level of care. So your role is to help engage with them and try to help mitigate that situation. The answering service of the voicemail with the agency's after-hours contact number, that voicemail should not direct behavioral health numbers to call 911 for BH issues or the emergency department unless their emergency is life-threatening. So it could be that that clarity needs to be there in that message that's left for the member. Each contracted provider should also make sure that the member has a 24/7, 365 telephone availability to access you after hours, and that access should connect them to a clinician or a QP. And again, it cannot be 911 or the partner's Hope line that you're directing people to as their first line response to get assistance after hours. The contact shouldn't be the hospital or mobile crisis team as their first line unless that service is also being provided under contract with us or unless the provider has subcontracted with us and pays providers directly for emergency backup services. Providers may consult and refer directly to some sort of mobile crisis management after the first responder intervention has failed. So that is always possible as a second level if that first responder situation was not able to help calm the patient member down. Providers don't need to go through access to care to make that kind of referral to mobile crisis management. So we're encouraging all agencies to really review your own processes. What is it that you expect for the members that you serve? What is it you expect for your staff? What should your process be? Is it working well? Does it need to be tweaked? Maybe assess for some weak points. And be mindful that we'll be mystery shopping again soon to see if the feedback is different this time, and we'll definitely keep you updated on that. It's important to remember that crisis plans should incorporate any limitations or restrictions listed in individual enhanced service definitions. There's details, especially for like ACT, intensive in-home, MST. They state that the members of the team can respond to the consumer that's being served. So it's very specific that the relationship between your team member and the consumer is upheld during a crisis. Mobile crisis can't be funded for that. And then comprehensive providers that have mobile crisis management teams should not use that team as the first responder because it doesn't meet the intent of the first responder from the service definition. So now we're going to move on to some UM updates. Our next presenter is Jessie Green, UM Supervisor. Jessie?
Good afternoon, everyone. Let's go ahead and start with the new Community Support Team CST service definition, and that's in Clinical Coverage Policy 8A6. There was a provider alert that recently went out. It was issued January 31st, 2020, and effective February 1, 2020, providers may begin submitting service authorization requests for Community Support Team under the definitions list, Community Support Team, and the services code list all services. SARS may be submitted for members with either Medicaid or state-funded services. So the following CST codes and modifiers will be included in the all services bundled list. And I'm going to read over them just once, but I won't repeat myself. I just want you guys to all be aware of the new codes. That's H2015H2U1, that's for the CST Peer Support Specialist. H2015HTU1DJ is for the CST DOJ Peer Support Specialist, that's for our Department of Justice consumers. H2015HTHM is the CST Paraprofessional. And the H2015-HTHMDJ is for the DOJ paraprofessional. The H201-HTHN-CST qualified professional or associate professional. And you can see again there the DJ modifier, same code, but just specifies that the member is a DOJ member. And then we have H2015-HTHF, which is a CST substance use counselor who has to be an LCAS, a provisionally licensed LCAS, a CCS, or a CSAC, and that's specific per the service definition. And then you can see there the DJ modifier for that code. And then we have H2015-HTHO, which is the CST licensed team lead, and again, the DJ code modifier added for DOJ members. Next, the alert states that both Medicaid and state-funded members may receive CST beyond 6 months of services if they have a comprehensive clinical assessment, addendum, or a new CCA that recommends that the member continue CST after 6 months of service. The CCA addendum may be completed by any licensed clinician at the provider agency. A new service order is not required at or after 6 months of service. A new service order should be completed annually. The Community Support Team Retroactive Service Authorization Request, this came out in the provider alert. It specifies that Partners Utilization Management, will allow the submission of retroactive SARS for Medicaid-funded CST for review back to December 16, 2019. In the case of members seeking stable housing, providers must identify when the member started permanent supportive housing services, and all retroactive SARS must be submitted to Partners by February 29, 2020, so that deadline has come and gone. This does not apply to members receiving state-funded services, and I'll just give you an alert that we recently came out with that updates on state-funded services. I'm going to give that to you in just a moment. So, Provider Alert issued March 2nd, 2020. On January 31st, 2020, Partners released a provider alert regarding CST retroactive SARS for state-funded members. This alert instructed providers not to submit retro SARS for state-funded CST members. So this is the correction I was talking about earlier. The state CST code, H2015HT, was indated on December 31st, 2019 in NC Tracks. For services beginning January 1st, 2020, providers will need to submit state benefit claims with the new CST codes showing a secondary modifier. State benefit claims dated January 1st, 2020 that are currently submitted with procedure code H2015HT will be recouped. Also, providers will need to submit retro SARS for state-funded CST members who do not have an authorization in place utilizing the new code. will process retro SARS back to January 1st, 2020. Please remember to submit SARS under the definitions list, community support team, and services code list, all services. All retro SARS must be submitted to Partners by March 31st, 2020. So that deadline is coming up soon. Just make sure you pay attention to that. If you have any additional questions regarding claims, please contact the claims department at claimsdepartment@partnersbhm.org. That's their email address. If you have any additional questions regarding SARS submissions, you can contact the Mental Health and Substance Use Work Group at 704-842-6436. All right, next we're going to go over the new CST benefit grid for Medicaid and state-funded adults. Under service description, don't worry, I'm not going to read all of those codes out again as I already read them, but we will go into the benefit limit. For initials, for CST, you have a pass-through of 36 units for 30 days, and that's only once per treatment episode, once per fiscal year. For the first concurrent, you have up to 128 units per 60 days. For those seeking permanent supportive housing, up to 120 units for 60 days. And for the second concurrent, you can have up to 192 units per 90 days. And for those seeking permanent supportive housing, you can have up to 630 units for 90 days. The level of care locus is a range of 2 to 4. The level of care ASAM is a range of 1 to 2.5. The clinical coverage policy source is Clinical Coverage Policy 8A6. And for documentation requirements, a notification SAR is required for pass-through on initial service authorization request. And for the first concurrent, we need a CCA, a PCP, and a comprehensive crisis plan. The service order is also required and is due on or before the first date of service. And for those seeking permanent supportive housing, a housing goal must be included on the PCP. For the second concurrent, we need an updated PCP, and we need a new CCA or CCA addendum if the request exceeds 6 months for the calendar year. And for those seeking permanent supportive housing, again, a housing goal must be included on the PCP. There were some changes recently to Assertive Community Treatment Team Act benefit grid. The changes are in red, and this is for Medicaid. So there was a change to the initial authorization. We will now authorize 4 units for 30 days, and that is based on the documentation requirements. So in the service definition, it states that you have up to 15 days to create your PCP. So in an effort to be less restrictive than the Act service definition, we changed our benefit limit. So you can now submit for 4 units for 30 days with a CCA and a service order. That's all that's required. The service orders are valid for 1 year, and then you'll need that full PCP required by the first concurrent authorization. Now, we want to let you know as a disclaimer, the note at the bottom of the grid says, if the provider submits the full PCP, comprehensive crisis plan, CCA, and service order within the initial authorization, we'll go ahead and give you 24 units per 6 months if the member meets medical necessity. And just wanting to let you know that you can still request that 24 units per 6 months for Medicaid members for your initial request, but you would just need to provide all of that documentation in order to do so. So for state, it's very similar. The initial 4 units for 30 days, and you can ask for that if you have a CCA and service order. And the service order is valid for 1 year, but you'll need to create that full PCP by the first concurrent authorization. Or if you have the full PCP, the full comprehensive crisis plan, CCA, and service order for that initial auth, you can go ahead and request 16 units for 4 months. All right, so there was another provider alert issued on peer support services, and that's Clinical Coverage Policy 8G. That was issued February 19th, 2020, and it was pertaining to authorizations and documentation. Partners will align the auth requirements for both state and Medicaid-funded peer support services. There will be 64 unmanaged units for peer support, which is more than the service definition actually allows, so we're being more lenient. And you can do that regardless of funding source. So that's going to be for state and Medicaid. And when the provider wants to request more units beyond that unmanaged limit, the provider must submit a service order, a person-centered plan, and a comprehensive clinical assessment. It's really important for peer support services to note that the service order must be signed on the first day of service. The PCP and the CCA should be completed during the unmanaged visits and ready to submit with the first auth request beyond the unmanaged allowance. And this change was effective February 17th, 2020. We recognize that state-funded peer support units have been unmanaged up to this point, so for providers delivering state-funded peer support, you have until April 1st, 2020 to submit a service auth request with all that required documentation, and that deadline is coming up, so just pay attention to that. So for service orders, there have been questions to partners about what should be included with the standalone service order. And the following elements must be captured in the service order: the full name of the member, their date of birth, the service ordered, the diagnosis code, the signature of the ordering practitioner, and the credential of the ordering practitioner. All right, next, training requirements for peer support. Providers have asked questions about the training requirements, and trainings can be face-to-face, webinar, or conducted by internal staff who have their certificate from a Train the Trainer session. And there must be a certificate for each peer support employee signed by the trainer and kept in their personnel file. All right, so there were some changes to the peer support services benefit grid for Medicaid and state. And basically the biggest change was that the Medicaid peer support benefit grid now mirrors the state-funded peer support grid. So I'm not going to go over all of those codes, but I will go over the benefit limit. You can see there are different codes for Medicaid peer support and state peer support. So just pay attention to that. For instance, for state peer support, we do have an 80038HK peer support individual timely follow-up code. And then the DOJ, Department of Justice code for Medicaid is 80038HQ-DJ peer support group. And then there's actually one for peer support individual as well, 80038DJ. So most of the codes align except for those exceptions. All right, so for the benefit limit, no auth is required for those who receive 64 unmanaged units. And then, of course, you have to submit a SAR for prior approval after you reach that unmanaged limit. And then the initial is 270 units per 90 days, and then the concurrent is 270 units per 90 days. The level of care locus score has to be a 1, and the level of care ASAM score needs to be a 1. The clinical coverage policy is 8G, and then we went over these requirements before for the documentation, but there it's just stating again exactly what is needed for the initial, a CCA, PCP, service order, and CCP, and for the concurrent and updated PCP, and of course the requirements for a service order. All right, retroactive Medicaid service auth request. Effective February 24th, 2020, Partners UM will review requests for retroactive Medicaid requests within 90 days from the modified date in NC Tracks. This is a change from the 30-day time frame, which was posted back in February 2019, Provider Bulletin number 90. All retro SARs must be submitted to UM for medical necessity review. And for further questions on retro Medicaid requests, you can contact the MHSU UM work group at 704-842-6436.
Thank you, Jessie.
Thanks.
And as a trainer for Provider Network, I will reiterate your comments about peer support training. We have also been getting some questions from providers about that. We're referring providers to the state website for peer support training. And we have learned that for the training that can be done on-site by the agency, our monitoring team just stresses that if you're providing that you do create a certificate, because the monitoring team will look for that certificate. I know Jessie mentioned that, but I just wanted to reiterate that some of it you can provide, but that certificate's what the monitoring team will look for. Thank you very much. Our next topic comes from our Program Integrity Department. Ms. Joy Chestnut is going to speak on reducing the risk of overpayment. So take it away, Joy.
All right, good afternoon, everyone. Before we get started, I would like to provide a brief overview of why we have a Program Integrity Department here within Partners, as well as some of the tasks and responsibilities that we do on a day-to-day basis. So Partners, BHM, and the providers within the healthcare network, we all have the responsibility of providing a high-quality, accessible healthcare system that integrates physical and behavioral health in a manner that is quality-driven, compliant, outcome-focused, and effective to meet the needs of the members that we serve. It is through the dedication of our providers and stakeholders that we can be successful in meeting these assurances and maintaining good stewardship of the public funds. So with that being said, here within Partners, the Program Integrity Department, we help to meet these assurances through focus on prevention, detection, and resolution of healthcare fraud, waste, and financial abuse. And one of our main responsibilities within the PI department is for us to conduct audits and investigations as part of Partners' overall compliance program. So with that being said, our department wanted to put together a training, and today we will focus on where do we find the service rules for service orders, comprehensive clinical assessments, and person-centered plans, what must be included in a service order, a comprehensive clinical assessment, and person-centered plan, and last but not least, what are the requirements or the signature requirements of a service order, CCA, and PCP. Because we work in the healthcare industry and people's lives could be at stake if care is not administered properly, we have a lot of laws, rules, and regulations that surround the work that we do. As providers, it is expected that everyone complies with all applicable agreements, federal, state, and local laws and regulations to ensure that the services that are being provided to our members are in accordance with the federal and state regulations, and that most importantly, documentation and billing practices of our providers demonstrate accuracy and integrity. The following slides will contain resources and the rules, manuals, and statutes that give the authority to set the requirements that as providers, you and your staff should be familiar with. On this slide here, the state plan is essentially the agreement between the U.S. Department of Health and Human Services and our state of North Carolina. The state plan lays out how North Carolina is to administer the Medicaid funds it receives and includes many requirements providers must follow. Some of those requirements are also incorporated into the North Carolina General Statutes as well as the North Carolina Administrative Code. The official posting of all mental health, substance use disorder, and intellectual and developmental disability service definitions are found within the various clinical coverage policies, and these policies are published by the North Carolina Division of Health Benefits, DHB, which was formerly known as North Carolina Division of Medical Assistance, DMA. The clinical coverage policies best describes the policies and procedures that providers should follow to receive reimbursement for covered services provided to the members. It sets forth the basic requirements for providers to bill mental health and substance services to Medicaid and North Carolina Health Choice. This slide here contains a listing of our North Carolina Medicaid behavioral health clinical coverage policies. I'm not going to go through all two of them, but we'll just leave it up here briefly so that everyone can kind of see at a glance where these policies are located. And this list here does include our new community support team as well as peer support services definition. The next slide contains a listing of service definitions for services that are funded through the state. So again, I will not go through each one, but here are the services there. Partners Provider Knowledge Base is another great resource for you all operating within our network. Our Provider Knowledge Base provides information on trainings, links to tools, B3 service definitions, and in lieu of services, among other things. Another important resource available on our Provider Knowledge Base, as you can see over to the right, is our Provider Operations Manual. The Provider Manual is updated quarterly, and it outlines the requirements and responsibilities of those in our provider network. There have been numerous changes in the mental health, intellectual, developmental disabilities, substance use service system, some of which have had a direct impact on how providers maintain their records, how services are documented in the service record, just to name a few. The manual that we frequently reference, and when I say we, us in Program Integrity, we Use of Records Management and Documentation Manual, which is commonly referred to as APSM 45-2. This manual assures that all relevant clinical information is captured, as well as it shows how providers should appropriately document anything within the member's service record. And on this slide here, go back one more. On this slide here, where it says Management and Documentation Manual, Chapter 3, Chapter 4, and Chapter 5 is where you guys will be able to find the information that I'll be discussing in greater detail throughout the remaining of the PowerPoint presentation. So for the next following slides, what I would like to do is go through the requirements of a service order, CCA, and PCP, as found in APSM 45-2 in our clinical coverage policies, and then last but least, the Person-Centered Planning Instruction Manual. APSM 45-2 states that all mental health, intellectual, or developmental disabilities and substance use service providers, services reimbursed by Medicaid, must be ordered prior to or on the day of the service and reordered at a minimum on an annual basis. The dated signature of the appropriate professional in the designated service order section of the PCP of the services outlined in the PCP becomes the service order. And just another reminder that all service orders must be renewed on an annual basis. Now, there are some situations when a treatment plan is used in lieu of a PCP. For instance, when we have a member who is receiving outpatient treatment services only, and in this case, when a treatment plan or a service plan is being used instead of a PCP, a separate service order is required for the services listed in the plan unless the format provides for orders to be signed on the service plan or unless the service itself does not stipulate the need for an order. The service order must be signed and dated by the appropriate professional as described in Chapter 3 of APSM 45-2, again, prior to or on the date of service, and it must be filed in the member's record. Providers of Medicaid-covered outpatient treatment services must also follow the specific requirements that's outlined in Clinical Coverage Policy 8C, the service orders. And Clinical Coverage Policy 8C states the following: a written service order by a physician, licensed psychologist, nurse practitioner, or physician assistant is required for associate level professionals prior to or on the first date of treatment. There are some licensed professionals that do not require a separate written order, and those individuals would be a licensed psychologist, an LP, a licensed professional counselor, our LPCs, licensed clinical social worker, our LCSWs, licensed marriage and family therapist, LMFT, licensed clinical addiction specialist, LCAS, and then our licensed physician assistants, a PA. These licensed professionals that I just identified are to document the service or services that they are providing, document the medical necessity of the service or services being provided, and documentation is to be signed by the licensed professional providing the service, and the service order must be signed prior to or on the first date of service. And I'm really stressing that prior to or on the first date of treatment, because that is one of the biggest things that we do see that comes through our department for us to go back and look at. The provider signed treatment plan, in this case, again, does serve as the service order. According to 10A, North Carolina Administrative Code 27G, a CCA that demonstrates medical necessity must be completed by a licensed professional prior to provision of outpatient therapy services, and this does include individual, family, and group therapy. APSM 45-2 requires that a CCA be completed by a licensed clinician prior to service delivery. And even though the CCA does not have a designated format, please keep in mind that there are basic required elements of a CCA. And both APSM 45-2 and Clinical Coverage Policy 8C describes the basic required elements of a CCA. One thing that I would highly recommend to all providers is to definitely make sure that, and again, looking at those basic required elements, that you look at both the APSM 45-2 as well as the Clinical Coverage Policy 8C. So here on this slide, I did include all of the following elements from both APSM 45-2 as well as Clinical Coverage Policy 8C. So A through D on this slide describes, again, some of the elements, well, all of the elements that must be included on a CCA. And then our next slide continues to show the elements that we would need to include in our CCA. The next focus point would be PCPs, person-centered plans. A person-centered plan is required for most Medicaid-funded mental health, intellectual, or developmental disabilities and substance use services. A PCP is required for all services delineated in CCP 8A, Clinical Coverage Policy 8A, with some exceptions such as assessments and crisis services such as diagnostic assessments. When a PCP is not required, a plan of care, service plan, or treatment plan that's consistent with and supportive of the service provided and within professional standards of practice is required on or before the day the service is delivered. One exception to this time frame is that providers of outpatient behavioral health services covered under the Medicaid Clinical Coverage Policy of 8C, they are required to have an individualized service plan in place within 15 business days of the first face-to-face contact with the individual. And for North Carolina Innovations and individual support plans that are used, the ISP, there are specific requirements and guidelines that are outlined in Clinical Coverage Policy 8P, P as in Paul, that you guys would want to go back and reference to. Please keep in mind that the PCP must be must be developed and written by a QP, a qualified professional, or a licensed professional according to the requirements of the specific service definition. APSM 45-2 speaks to some of the components of the PCP, primarily those related to authorization, content, and documentation. And our person-centered planning instructions manual speaks to the required content and documentation requirements that should actually be in a PCP. The PCP consists of 4 main parts, each of which is required, and when we combine all of those 4 parts together, we actually have now what's called our whole person-centered plan. The 4 required components of the PCP includes the 1-page profile, the action plan, which is where the goals are located at, the comprehensive crisis prevention and intervention plan, which I refer to as the Excel document, and then last but least, our signature page. The signature page consists of 4 parts with various attestations as applicable to each section. And so in part 1 of that signature page, we would want to focus on the person that's receiving services, and that could be for the individual and or the legally responsible person. Part 2 of that signature page is for the person responsible for the PCP, which would be the qualified professional or the licensed professional. Part 3 would be the service order, and part 4 would be the signatures of other team members. The date of the plan, which is the PCP completion date, is the date that the QP or the LP, per the service definition, completes the PCP plan, signs, and dates the signature page. All signatures must contain the appropriate credentials, date, and licensure. It is highly recommended that when signing those plans that all signatures are legible and contain at least the first and last name of the person that's signing it. The signature is authenticated when the appropriate professional constituting the service order, the individual and or legally responsible person, and the person responsible for the plan, which is the QP or the LP, each enters the date next to their signature. So with here, I would want to go back and iterate again the importance of making sure that when you sign your plans, make sure that each individual signature has a date that is beside it. We will not honor any plans that does not have that date beside it. That date is what, again, allows that document to become a true, authentic document. The person that's receiving the services and or the licensed responsible person is required to sign and date in Part 1, and also make sure the appropriate boxes are also being checked, which indicates the confirmation and agreement with the services and or supports that are outlined in the PCP. The qualified professional or licensed professional responsible for developing the PCP must also sign and date the plan. For our Medicaid covered services, one of the following professionals are able to sign and date the PCP, and that would be our licensed physician, a doctor of osteopathy, licensed psychologist, or a licensed physician assistant, or a licensed nurse practitioner. So those would be the following professionals that must sign and date that in order for that to become the service order. And then last but not least, for our state-funded services, it is recommended that one of 4 professionals that I just described actually sign the PCP in Part 3, Section A of the service order section. And please keep in mind that a PCP is valid for billing. The last of the 3 required signatures is in place. The dated signature of the person whom the plan belongs to, the dated signature of the QP or LP that wrote the plan, the dated signature of the person ordering the service. All of those 3 things must be in place. 3 signatures must be in place in order for the PCP to be valid. And so in conclusion, please keep in mind that it is all providers' responsibility to stay abreast of the requirements for delivering the services that you are credentialed and contracted to provide within our provider network. That concludes my portion. If anyone has any questions or anything that they would like additional information on, my information is here on this slide, as well as information on how to actually report fraud or abuse that may be occurring within your provider agency, or something that you may hear that includes provider fraud, waste, or abuse. And thank you.
Thank you, Joy. Our next presenter today is Keisha Sandage. She's going to speak on the Incident Response Improvement System. Keisha, are you with us this afternoon?
I'm sorry, I was on mute. Apologize for that.
That's
I just
okay.
want to make mention or make note that we will have a full training on March 17th, 2020, from 10:30 to 12 p.m. This will be in the form of a webinar, so this will only be an overview today. All right, so we can go to that first slide. Definition of an incident: any happening that is not consistent with routine care of a consumer that is likely to result in adverse effects. There are 3 types of response levels that are determined by the potential and or actual severity of the incident to the well-being of the member. Additionally, there are 9 categories of incidences. There are death, restrictive interventions, any injuries, abuse, neglect, or exploitation, suspension of a member from a program, medication errors, any consumer or member behaviors, and fires. Level 1 incident reports are not entered into IRIS, and this should be maintained in the provider's records. You may do that either via electronically, or you may have those in a notebook in a confidential location. Level 1 incident reports do not significantly threaten the health or safety of the consumer. Level 2 incidents are entered into the IRIS system within 72 hours. These incidents usually involve threats to the health and safety of the consumer and or others. These are also deaths that are due to natural causes or terminal illness. Level 3 incidents must be reported to the MCO via fax, email, or phone within 24 hours and entered into the IRIS system within 72 hours of learning of the incident. Level 3 incidents are those that can have resulted in permanent physical or psychological impairment to the consumer, or may not be subject to media attention and pose a significant danger to our community. Who should report? This information is found on page 4 of the IRIS reporting manual. Any member that is under a provider's care or has been under a provider's care within 90 days of being aware of the incident is expected to report the incident. Any providers that are publicly funded services licensed under North Carolina General Statute 122C, your category A and B providers, not category A or C providers, and again, this is explained on page 4. Out-of-state providers should fax their IRIS reports to myself or Deborah Jackson at the number listed here, 704-884-2620, as you do not have an IRIS out. The next slide talks about which agencies should be notified of the incident. Depending on the level, a lot of these agencies will be offered by the IRIS system, and it will ask who you've spoken to. It will ask what day and what time you have spoken to this individual. So when you go to the report sections in IRIS, the incident comment should explain to us, the reader, what happened, how staff responded. So pretty much who, what, when, where, and how. The supervisory action should help us understand what happened in the incident and how it will be further addressed to make sure the incident does not reoccur. We are looking to see how the incident will be prevented in the future for this member. Next, we have some web submission tips. So who should complete this incident report? The person with the most knowledge should talk to us about what happened in this incident. Always, always, always print a copy for your records and make sure you save the incident report number. That number should not be provided to anyone, not even the MCO, as this represents the Social Security number for this report and allows another person to enter into this incident report. If you have lost the incident report number, you may email us. There is a slide at the end of this presentation that gives you our IRIS email address, and let us know that you've lost an incident report. Do not re-enter an incident report before checking with us, as this will cause a duplication. So we have identified concerns with late submissions. So just wanted to talk just a little bit about what we consider a late submission. So all incident reports should be entered into IRIS within 72 hours. Each provider is being looked at to see if they've met an 85% submission guideline per contact. If you need more information about this, please feel free to call myself or Deborah Jackson. Consumer rights officers will begin, and we have already began in February, attending our monitoring visits. And when we come to monitoring visits, we look at your level 1 incident reports. We review IRIS before coming on site to see if you have submitted any incident reports in IRIS. And we will be looking to see when the last report in IRIS was submitted. This next slide talks about resubmitting an incident report. As I stated earlier, do not, if you feel you may not have entered an incident report, do not enter another one without calling us. This walks you through how to resubmit an incident report if you need to update it. What happens is when you submit an incident report to the MCO, we review it and we may have comments, we may need clarification on things, and most times we do not call the provider. We enter into IRIS whatever questions we may have, and we request that you respond back within that incident report. What we will do is send an email, so whichever staff has been directed to monitor your IRIS reports should be looking in every so often to see if that incident report has either been closed by the MCO or additional comments have been requested by the MCO or the state. Incident reports are, sorry, my computer just went out.
I'm sorry, Keisha. The slide talked about confidentiality and that the incident.
I'm looking at the slides now, thank you.
Okay.
So all incident reports are confidential and protected, and it gives you the general statutes that protect those incident reports. And just make sure that incident reports are not logged in a member's record. The next slide looks at other resources. If you have new staff coming into your agency, I would suggest you print them out, the technical manual and the reporting manual. That at least gives them a guideline on how to enter incident reports in the IRIS and how to level those incident reports. At any given time, you may give us an email or a call if you have questions about leveling or an incident in general. And the next slide tells you the 2 consumer rights officers, which counties we cover and which level of reports we cover. If you have a level 3 incident report, Deborah can be reached either via the fax below or the IRIS email address below.
Thank you, Keisha.
Thank you so much.
And as she mentioned, we do have a more detailed training for IRIS that is on the training calendar that you can register for. That is a webinar that will go into more detail, and especially if you have staff who might need a refresher or newer staff working with IRIS, that would be a great learning opportunity if you will register them for that class. So our next presenter, Danielle, are you on the line yet, Danielle?
Yes, I am.
Okay. If you want to go ahead with social determinants of health, thank you for being with us today.
Absolutely. Thank you. I'm going to give you all a quick snapshot of where we are currently at with our social determinants of health initiative. We have a total of 9,590 social determinants of health assessments completed. these were actually turned in from the life of our project. So that date range is May 1st of 2018, and this count was current as of February 29th, 2020. 362 of these did not have dates, but that is the range that we pulled this data from. Of that total number, 5,739 are the full 21 item survey. 3,851 are the state version, asking only questions specifically pertaining to the last 12 months. Currently, 3,811 of those 5,739. So that's of just the one taking the 21 item survey had 3 or more needs identified. We took a look at the current needs indicated from these assessments. These needs are ranked from most to least by percent. So taking a look at the current needs, 54.2% of the individuals completing these assessments needed insurance. 52.7% needed employment. 46.8% needed medication. And you all are familiar with the current needs of the populations that you're working with, but just seeing how many people needed the insurance, employment, medication, transportation, food, had a food insecurity, maybe their food was gone too early, housing risk, feeling unsafe, and needed help with their utilities. These numbers are very telling for the needs of the population that you all work with. What's next with social determinants of health? We are currently transitioning to electronic submissions for social determinants of health assessment. A lot of our providers are still using paper copies. Some of you have maybe recently transitioned. We are asking providers to utilize PROMS. It's our electronic database to look at these outcome measures, or a data entry template, which is on an Excel spreadsheet that can be completed on a monthly basis. So it really just depends on your agency and what works best for you and your agency as far as which method to go with. But we are asking that you all participate in our transition to the electronic submission instead of the paper submission. If I haven't already reached out to you about it, that's something that I will be doing in the near future. If you're interested in learning more about our social determinants of health initiative, or have some questions about what you currently have in place, and maybe you want to talk more about processes that might work best for your agency, please do contact me. My contact information is listed on the slide. And thank you so much. That's all I have.
Thank you, Danielle. Our Provider Operations Manual. In case you're not aware, Partners goes through a thorough review of the Provider Operations Manual once a quarter. So we are working on the update now for March, and our goal is to be able to publish this when the communication bulletin comes out next time, so it can be published at the same time. So be aware that that will be reposted on the knowledge base as soon as we finish updating it. Some of the items that we know will have updated information for, there will be some information in the manual about a member portal on the Partners website that we'll be encouraging our members to use, and we would appreciate your help in making them aware that that's available to them. There will be written clarification regarding a prepayment claims review process for program integrity. So that will be clarified in the manual. There'll be information for the process of how to request changes to an enrolled member's record through our Access to Care department. So those are 3 changes that we know will be in there. And again, when it's published, it will be put on the provider knowledge base, and there should be a mention of it in the next communication bulletin. Our previous communication bulletin that came out was number 102. It again is now posted to the provider knowledge base. This one was very robust, and it had important information for the various topics you see listed on the slide. The Community Needs Assessment Survey is active. We really rely on our providers to help us get the word out. We want as much feedback as possible regarding the Community Needs Assessment. A lot of decisions are made based on the results of the Community Needs Assessment Survey. So the more information we have in that survey, the better decisions that can be made for members, providers, and the various programs that we offer through partners. There's claims information and updates, the social determinants of health data, state updates regarding transition, joint communication bulletins are located there, program integrity news regarding some things that are happening within the state of New Jersey that are similar to the transition with North Carolina, and there's paybacks for ACT information there that happened in New Jersey that helps us know what to be mindful of here if you're an ACT provider in North Carolina. There's National Quality Forum information, including future trainings, provider alerts, and there are a lot of training opportunities. We are doing our best to fill our communication bulletins not only with the trainings that we offer at partners, but anytime we are becoming aware of other training opportunities available to you as providers. We want to be a hub of information for you to get you what you need. So we encourage you to take time to review this bulletin if you haven't done so already, because the next one will be coming out at the end of the month. And speaking of training opportunities, we have several provider trainings recently posted to our training calendar here at Partners. These are free to you as providers, but we do ask that you register. We are starting to see a trend that we have probably about a third of the folks that register may not be showing up for the classes that we are offering. And since these are free to you, I see how that might happen where you want to register to get a slot, but then if you get busy with what's happening at your agency, you may not be able to attend. We do have to limit our class sizes due to space, so we ask that if you do register and then find that you cannot attend, please let us know. We're starting to keep some wait lists for some courses, and we want to be able to make your slot available to someone on the wait list should you not be able to attend. The easiest way to reach us to notify for registration, your email confirmation of a class that you register for has information of how to cancel, or you can always reach us at training@partnersbhm.org. That's our email box for training. As you can see here, our provider open house is an opportunity that this came from the Provider Council, that sometimes providers want to be able to walk in and speak to leaders in different departments to get assistance one-to-one for technical assistance. So the Provider Open House is an opportunity not only for new providers, but any provider in our network. We're trying to have those once a month in Gastonia on the first Thursday of each month from 9 to 11. We have leaders from all the various departments there just sitting waiting for you to walk up and ask them any question you want to. You can drop in at your convenience anytime between 9 to 11. But again, we do ask that you register first. Last month, we only had 2 providers register, so we canceled that event. If we have enough people register, we're happy to do that, and a lot of people find it very helpful to be able to walk in and talk to someone face-to-face and get their questions answered. So we encourage you to take advantage of that. We have 3 classes that are coming up pretty soon. Person-Centered Thinking. This is the 2-day course that's required for many service definitions. It's being taught by someone from the learning community. Our March course got full very quickly. It's holding a wait list right now in case there's cancellations. We do have a course for person-centered thinking scheduled in April, the 15th and 16th in Gastonia, and May 4th and 5th in Hickory. I encourage you to register for those if you want to attend. We have an ethics class that has been a common request that we offer ethics. Many of you need that for your license. So we are scheduling that for April 28th in Gastonia. We have applied to have CEU credit for that. We've not gotten the formal approval, but we anticipate having that in place for the ethics class April 28th in Gastonia. And then there was a lot of talk today in the forum about PCPs and the importance of filling out those correctly for monitoring and PI purposes. So we will be having a course, Functional Elements of PCPs, April 29th. That will be held in Hickory. That has also been a common request for providers, and we're glad to be able to do that for you, April 29th in Hickory. Last, I want to thank the many of you that did fill out our survey for your training needs. We ended up having 119 responses. We are going through that data now, and the results of that survey will help drive additional trainings that we will be scheduling between now and the end of the year in 2020. So we appreciate your feedback. We know that we ask you to complete numerous surveys, and you can start having survey fatigue, but we greatly appreciate your feedback because it does help us plan better so that we can meet your needs better. So again, we want to thank you for joining us today. We do hope that this time has been helpful for you and it's given you information that you need. We are ending a little early today. That's going to give all of you about 45 minutes back to your day. Again, thank you, and you will be getting a brief survey from this. Your information or information that you give on that will give us ideas of what you would like for us to cover next quarter when we have our webinar again. So thanks to everyone. Have a beautiful afternoon. It looks like it's a nice sunny day out there. I hope everybody gets outside some. Thank you very much and have a good day.